The last talk is going to be by Dr. Hameed, and it's going to talk about ECLS and the future of trauma resuscitation. Dr. Hameed is a trauma surgeon and intensivist at the Vancouver General Hospital and an assistant professor of surgery at the University of British Columbia. He went to medical school and completed his surgical residency at the University of Alberta. For graduate school, he attended Harvard University and studied public health. And he was a fellow in trauma surgery and surgical critical care at the University of Miami. He spent 3 years in a surgical facility at the University of Calgary and after moved to Vancouver. He is currently the section head for trauma and emergency general surgery at VGH. Dr. Hameed chairs the research committee of the Trauma Association of Canada and is the immediate past chair of the Canadian Association of General Surgeons Committee. His research focuses on systems of trauma and acute care surgery. His research teams have received grants from the Canadian Institute for Health Research, the Michael Smith Foundation for Health Research, and other funding agencies for the work on disparities in injury risk and access to trauma systems in Canada. With that, welcome.
Thanks very much, Dr. Ree. To advance. We've heard many phenomenal talks today from this planet's leading authorities on trauma resuscitation and even lack of resuscitation. And now we're all up to speed with the state of the art in 2016. But imagine for a moment that the year is 2035 and you are on a high-tech mission to an environment without much oxygen. Actually, imagine that you're a red blood cell, okay? Is everybody imagining their red blood cell? You're an oxygen transporter. You're part of a living, breathing, healthy 37-year-old botanist who's doing some research with the Ares 3 mission on Mars. You can see from his monitors that he's working outside because his cardiac output is up. But everything is running beautifully. You're working too, transporting oxygen as usual, loading up in the lungs, and delivering smoothly to your grateful targets. Suddenly, there's a huge crash and you're thrown. The vessels you're sailing through are tumbling and tumbling, and there's complete chaos amongst your fellow red blood cells. The situation is worst in the lungs. You see big tears in the arteries and veins of the chest, and some of your friends are even getting sucked through them into the lung parenchyma and maybe into the pleural space, and then who knows where. Worst of all, there's no oxygen. You shift your oxyhemoglobin dissociation curves to the right to unload more, but things are getting pretty bad. The chambers of the heart seem empty, and everything is slowing down. As Dr. Feliciano predicted in his first talk today, every organ you go through is looking pretty blue. In the lungs, you see neutrophils primed and ready to release inflammatory mediators, both elements of Fick's law, which governs diffusion through tissues, the surface area of the alveoli, and the difference in the partial pressure of gas across the alveoli seem to be failing. And you're just not picking up any oxygen as you struggle through the capillaries. In the liver, it's the same thing. Cells are shutting down in hypoxic environments, and inflammation is on the rise. You're offloading almost all of your oxygen, and the venous oxygen saturation is plummeting. Even in the kidney, things are looking bad, with cell death and necrosis setting in. As a red blood cell of a biologist, you know what's happening. Blood loss, shock, cellular dysfunction, cell death, and multi-organ failure. Your time is up. But you knew the risks when you signed up to be a red blood cell on a dangerous mission. But suddenly, again, something unexpected happens. You find yourself leaving the femoral vein. At first, you think you might be bleeding out, maybe through a laceration in the vein, but you find you're actually being whisked along with other red cells in a clear plastic tube. It's pretty bright out there. You are in the first segment of an extracorporeal membrane oxygenation system, or an Ecmo circuit. You know Mark Watney's heart was fine and the lungs were injured, so this is probably a veno-venous circuit primarily for gas exchange. The view from here is pretty wild. Here are some relieved-looking trauma surgeons. The pressure in this segment is pretty negative. You're clearly getting sucked into something. As you move forward, you're glad that there are no injection ports in this segment, because with the negative pressure, you wouldn't want air to get inadvertently sucked into the system. One thing you notice is that the tube is lined on the inside with a biocompatible coating that uses polypeptides to bind high molecular weight heparin polypeptide to the inner polymer of the tubing. You notice that because of this lining, and despite being in a synthetic conduit, there's minimal coagulation and complement activation, there's minimal thrombocyte adhesion and thrombogenesis, and minimal adherence of leukocytes. Despite the negative pressure, the flow is pretty smooth and fast. You remember Poiseuille's law that states that flow through a tube is proportional to the pressure exerted and also proportional to the fourth power of the radius of the tube. It's inversely proportional to the viscosity of the fluid and the length of the tube. The tube seems long to you from the inside, but at 28 French, the radius is great and the flow is good. Suddenly, you get swept into a vortex, spinning just like the simulator at NASA did when you were training. Only this time, it's spinning at about 2,600 RPMs, as you see here. You're in a centrifugal pump, suspended by magnets and propelling you forward into the next segment of the circuit. The pump is linked to a flow monitor, and you can finally see that blood is actually flowing at a rate of 4.7 liters per minute, or more than half of Mark's own native cardiac output. More than half of his blood volume is entering the circuit every minute. Here's the outside view. So blood is sucked into the middle of this pump. You can see the impellers moving in the second image, and it's forced to the outside of the pump and into the outlet. The oxygenator is where the magic happens, and it's the next stage of your journey. This is the artificial lung of the Ecmo circuit. In the oxygenator, blood flow is directed through a large surface area of coiled silastic envelopes, or polymethylpentene hollow fiber membranes. These microporous envelopes, or hollow fibers, are the gas exchange area, as they are permeable to oxygen and carbon dioxide. Gas flow is added to the opposite side of the membrane in a countercurrent direction to blood flow, optimizing diffusion. The gas flow, which is also called the sweep gas, contains a high concentration of oxygen. You're feeling better already. It's important to note that blood flow is driven toward the oxygenator by the pump, and that the post-pump and therefore the oxygenator pressures are positive, making it less likely that the circuit will entrain air from the atmosphere at the site of the oxygenator. You've now been exposed to a lot of external surface area, 1.8 square meters in the oxygenator alone, and it's getting pretty cold. So the oxygenator is actually hooked up to a warming chamber that circulates sterile water to warm you back up to close to body temperature. And now, you're back from your mission, fully saturated with oxygen and ready to deliver. As you pass through the superior vena cava, the right heart, and the lungs, you immediately notice less hypoxic vasoconstriction in the lungs and less strain on the right side of the heart. And you notice that there's still some red cells who didn't get through the circuit and are still poorly oxygenated as they move through the damaged lungs. When the circuit and the native blood mixes, the oxygen saturation may be dragged down a bit, but it's probably okay. The pump is still sending 4.5 liters per minute of fully oxygenated blood through the circulation. So congratulations, red blood cells, mission accomplished, and you're home. You may be surprised to know that you're not the first RBC to go on a mission like this. The first successful ECMO was actually done in 1971 on a 24-year-old trauma patient with ARDS, right here in California. The experience, which was led by trauma surgeons, of course, triggered a massive interest in extracorporeal life support, including for trauma. The Extracorporeal Life Support Organization Registry, which started in 1990 now houses data on 73,596 of the sickest patients imaginable and reports an overall survival rate of 58%. It also has standard criteria for going on extracorporeal life support, including severe hypoxic respiratory failure, carbon dioxide retention, air leak syndromes, intubation of patients who are awaiting lung transplant, and immediate cardiac or respiratory collapse. But what about trauma? The 2008 CAESAR trial, which randomized 180 patients with severe respiratory failure from 68 centers around Leicester, England. These patients were randomized either to conventional ventilator management or to referral to a center that was capable of performing extracorporeal life support. That study really ushered in the modern era of scientific inquiry in this area. The CAESAR investigators found that survival without significant disability was 47% in the conventionally managed patients, and it was 63% in the group that was referred for ECLS. That's a relative risk favoring extracorporeal life support of 0.69. This was one of our first big signals that early initiation of ECLS may be beneficial. Subsequent experience with the SARS epidemic has reinforced the perception on a global scale. CAESAR included trauma patients, but what has our experience really been like in trauma? Is trauma too uncontrolled a situation for ECMO? Is the risk of anticoagulation to get through the circuit too high? Let's start by saying that ELSO contends that there are no absolute contraindications to ECLS, as each patient is considered individually with respect to the risks and benefits. I thought I'd run a few cases by you to see what you would do. So, a 27-year-old male is in a high-speed motor vehicle crash. He's hemoptysis, profound hypoxemia, and a pneumothorax with a fallen lung sign, and a massive air leak from his right chest tube. What's happening? How many people in the audience would put this patient, or would at least consider putting this patient on ECMO? It's a small minority, maybe 1 or 2% of the group. Well, there have been studies about the use of ECMO in trauma patients with tracheobronchial injuries. These are mostly case series or case reports. In this one, in the lower one here, you see a 32-month-old girl who was in a motor vehicle crash and ruptured her trachea, was put on VA ECMO close to the time of arresting, and then later transitioned to VV ECMO. During the case, while on VA ECMO, she was actually extubated so the tracheal repair could be done. She was put back on VV ECMO after the case and eventually went home and had a normal follow-up at 2 years. So it can be done. What about this next case? An 18-year-old male sustains multiple gunshot wounds to his mandible, neck, and chest. He's hemodynamically stable, but he has aspirated a large amount of blood and gastric contents. He's intubated, but oxygen saturations remain at 83% on 100% FiO2. How many of you would put this patient on ECMO? About this, a little bit more, maybe about, I'd estimate about 8% or so, maybe 8.5. So there are studies about ARDS in trauma and the impact of ECMO. In this one, we see a mortality rate of 24% in patients with trauma who experience acute lung injury or ARDS. This is a bigger series of 52 patients by Reed that describes ECMO in ARDS after trauma. Most of these are blunt mechanism. You see a very high injury severity score here, and you see a little bit of anticoagulation sneaking into the circuit here. Mean time from trauma was 5 days to go on ECMO, and the duration of ECMO was on average 6 days. So in this table, the same study, you see from prior to initiation of extracorporeal life support to beyond, significant improvements in the PaO2 from 54 to 105 and above 100 into the 200s throughout the patient's hospital stay. So ECMO, in this study at least, improved oxygenation quite dramatically. Another study of 28 patients, traumatic lung injury treated by ECMO. Again, you see high injury severity. You see the use of anticoagulation even in a traumatized population. A duration of ECMO of 6 days and a pretty decent survival rate of 71%. Okay, what about in the C with hemorrhaging patients? A 43-year-old male with alcohol cirrhosis sustains a fall from a height. CT reveals a grade 4 liver laceration with extension toward the hepatic veins. Following CT, his abdomen distends and he has a transient fall in his blood pressure. His FAST is positive. How many of you would put this patient on a circuit? 0, almost 0. Because we did, so that's maybe 1 in this group. The advantage in this, our rationale for doing this was we were expecting a big injury, perhaps extending to the hepatic veins, and we expected a long battle with hypothermia. So we thought if we put him on veno-venous bypass, that could assist us in getting him on hepatic isolation, and also to keep him warm during the case. Interestingly, he did stay warm, and it sort of changed the paradigm of damage control because he wasn't one of these trauma patients that gets cold in your hands as the case progresses. He stayed warm and well resuscitated and even well oxygenated for the duration of the case. So some authors argue that ECLS can be used in patients who have a component of hemorrhage because the modern systems are smaller, they use centrifugal pumps with low priming volumes, the cannulas are smaller, and the circuits are coated with heparin. So some of the studies actually delay starting patients on systemic anticoagulation, relying on the bonding of the circuit with heparin to maintain anticoagulation. Okay, so there's more studies like this that you see here. They're all, again, small case series or even case reports. We moved on to D, or the neurologic assessment. What about using ECLS or Ecmo on patients with suspected traumatic brain injury? Well, here's a 32-year-old male who sustains a traumatic brain injury in a high-speed motorcycle crash. He undergoes a craniotomy for evacuation of epidural hematoma. On post-op day 3, he develops bilateral chest X-ray infiltrates and profoundly increased oxygen requirements. And would you put this patient on ECMO? A few bold people would do that. It is scary to put somebody on ECMO, and especially with the need that you might have to anticoagulate them. The Brain Trauma Foundation is very particular about maintaining perfusion and preventing hyperventilation or hypercapnia. And so one does have to pay attention to the blood gases, and it is tempting to consider using extracorporeal life support in traumatic brain injury. And in fact, there are reports, as you might have guessed in the literature, with case after case showing that you can actually put patients with traumatic brain injury on ECMO. You have to use a heparin-bonded circuit. You have to expect that there may be coagulation difficulties and hypercoagulability, and try to get them onto anticoagulation as soon as the clinical course permits. So you've seen a collection of studies in this short review that show some decent survival. These are patients who have airway injuries, ARDS, hemorrhagic shock, and even neurologic trauma. And now we might even push the envelope even further because the newer circuits are smaller and more portable, and we may be able to push extracorporeal life support even more into the front lines of trauma care, putting patients on the circuit faster, maybe down in the emergency department. So is this wise to continue to proceed in this direction? Well, this is a study by Dr. Ree and his colleagues that actually I think implies that we're getting better at managing ARDS. And maybe we don't need to pursue ECLS or ECMO in ARDS and trauma patients. Maybe what we're doing is safe and is achieving pretty good outcomes as it is. And certainly what we do now for respiratory failure is working, including low tidal volume ventilation, prone positioning, and nitric oxide, and numerous adjuncts. So what I was trying to show here is that the sum total of all the case series that we've seen in the literature is pretty small. And do we have enough evidence to continue to confidently pursue the wider application of ECLS in trauma? So in the studies that I've shown you, over 8 years, they've totaled about 85 trauma patients reported in the literature. 15% of those patients had invasive procedures while on ECMO. 30% of these patients had complications. So that's 85 patients overall. But if you consider that in the context of all ECLS patients in the ELSO database, there's 44,490 ECMO implementations during that same time period. So trauma, at least the reported cases of ECLS and trauma, is a very small minority of our overall experience with ECLS. So the point is, I think we still have a very small and new experience with ECMO, and I think we have to proceed on a case-by-case basis with caution. And there are reports of bleeding especially in traumatic brain injury on patients who have to go on ECLS. So here's the final case. A 21-year-old male sustains multiple hollow point gunshot wounds to the right lower chest and abdomen. His blood pressure in the trauma bay is undetectable, but he's rapidly transferred to the operating room where he goes into PEA. An anterolateral thoracotomy with a clamshell extension reveals a right lower lobe lung injury. The pulmonary hilum is cross-clamped along with the aorta. Exploratory laparotomy reveals extensive injuries to the liver, including the portal vein, SMV, and also the head of the pancreas. He loses his blood pressure again, and the end-tidal CO2 on the table is undetectable. What's happening here? Is there a role to put this patient on any type of bypass, considering the fact that he's young and has an entire lifetime ahead of him? Well, as you may have guessed, I've been motivated to study ECLS a little bit because of a few personal losses over the years. These have included a few adverse outcomes and even mortality in some of the cases that we just went through, in particular this one. This one is particularly hard because I think all of us feel that if we can get a patient to the operating room, there should be a great chance to get them through. But trauma patients who suffer cardiac arrest have very poor survival, perhaps as low as 7%. That was in a review by Dr. Ree. Putting trauma patients on VV ECMO for respiratory failure or VA ECMO for hemorrhagic shock has been found in numerous reports to be feasible, even without systemic anticoagulation. And the extreme example of this is putting a patient who's in traumatic arrest within 5 minutes of arriving at a trauma center on a cardiopulmonary bypass. This is a protocol that's being developed at the University of Pittsburgh. It's a feasibility study to evaluate the concept of emergency preservation and resuscitation. That is, placing an ECMO cannula in the aorta and flushing it with ice-cold sterile saline to cool down the heart and the brain and to preserve it for up to 3 hours while you can do damage control procedures on cardiopulmonary bypass. That type of early preservation, as I mentioned, might buy up to 3 hours to move to the operating room to repair injuries on full cardiopulmonary bypass. I can't wait to see what happens with this, and many of you in the audience may already know what's happening. Anyway, I'm very grateful to my friend Dr. Emily Yosh in Vancouver, who's taught me quite a bit about ECMO and trauma, and to the Ecmo program at the University of Alberta, which has an inspiring training program. And I'm also grateful to the conference organizers and to all of you for thinking through these issues with me. I'll conclude by saying that ECLS is not contraindicated in trauma, but it requires an innovative and collaborative approach, careful patient selection, and of course, more original studies and deeper analyses of national and international registries. And who knows, someday ECLS and trauma may become more universal. Thank you very much.
All right, thank you. Any questions from the audience? Well, I have several questions, actually. What happens with the ethical dilemma about doing a procedure that's not been proven is not standard? So when you feel that the majority of the surgeons would not do something, but you try it because you feel in your heart, isn't that just experimentation? Or how do you feel about taking a patient that would have a contraindication and trying to see what happens when they put them on ECMO?
Yeah, Dr. Rhea, I think that's a critical question, and I don't know the answer to that. We heard in Dr. Feliciano's talk about where was the FDA when they had developed stent grafts. And I think this is a similar situation when we're right at the extremes of medical and surgical knowledge in patients who would otherwise die. So I know that there are examples of unethical practice in these extremes of life. So I think that these cases should be taken on an individual basis. Every trauma patient is unique, and every trauma patient is prone to a unique set of complications. And so the best answer I could give, Dr. Reed, is to say that you could just weigh the risks and benefits of any technology that you're applying for a patient, and make sure that there's full disclosure to the patient and their family about what you're trying to achieve. Patient selection, I think, is an important issue also for futility. If the patient doesn't seem like they'll be salvageable, then putting them through a course of aggressive management would also be unethical as well. So it is an area of extreme caution, I think.
Despite admonitions from Dr. What?
Could you introduce yourself to the audience?
Hi, Dave Notrika. Hey, thank you, Dr. Reed.
The internet audience.
Yes, okay. When I was in Houston, Dr. Maddox warned me that going around the hospital with an Ecmo circuit and putting people on cardiac bypass might not be the best idea. But despite that, we actually have an Ecmo CPR program at Phoenix Children's, and we've been doing that on patients who had died in the hospital. What are your thoughts about doing that for trauma, where you actually have a set-up eCPR program where you just plan to put them on ECMO?
Yeah, that's a great question, and maybe I'll run out the clock with this question. I think we have a lot to learn from pediatric trauma, and that's in fact the course on ECMO that I took was run by a children's center with a very big experience in ECLS as a referral center as well. The conceptual problem that I have with putting patients on circuit who are in hypovolemic shock is, how do you actually do it when the vessels are empty and you're trying to resuscitate them at the same time? Our perfusionists sometimes say that when you put patients on bypass, you can actually hook suctions up to the blood flow, and you can capture all the blood flow and recirculate it through a complete bypass. So that made me think that trauma surgeons should be more familiar with how to put patients on cardiopulmonary bypass, because in an extreme event, it could be life-saving. I know in Vancouver, we have just started a regional eCPR program, so this is for out-of-hospital cardiac arrest and not for trauma. And I think we are still a long way off from having a formal eCPR program. I think mainly because of the logistical challenge. With eCPR for cardiac arrest, you have a full circulatory system, so you can put patients on external compressions, use a compression machine to get optimal compressions and maintain perfusion. But for a trauma patient, I don't know, Dr. Notrika, maybe you would know, how do you bridge them with perfusion until such time as you can get them on the ECLS circuit and eCPR, because their intravascular volume is depleted and you won't be able to generate any pulses with CPR.
Dr. Maddox says I don't have to.
Dr. Maddox.
Thank you very much. This is an important question, and one which needs to be... I'm Kenneth Maddox, Houston. I've been alluded to in the last talk and in the last discussion. I thought a number of points needed to be clarified. Number one, when we went around the hospital, the suspicion was pulmonary embolism. And we developed a portable cardiopulmonary bypass machine which I could prime and cannulate and have somebody on the pump within 15 minutes of my notification. And the current circuits are not amenable to that easy kind of priming unless we develop another one. For pulmonary embolism, if massive central pulmonary embolism was the cause of the arrest, we had a 50% survival, walk out of hospital, not dead brain. And that's still the best results in the world. If they had a heart attack, or they were GI bleeding, or something else, and we didn't know what it was until we got them on the pump and found out what it really was, we had no survivors. In addition to that, I did not publish 20 people or so who had hemorrhagic shock that I took the same machine down to the shock room and threw them on the pump. For hemorrhagic shock, we had 0 survivors, 0 survivors. We had a couple of deep hypothermia patients that were out cold out in the field that survived and walked out of the hospital. But they had a full volume. For those for the waiver of consent, FDA has allowed a mechanism, but it is very strict now, and you have to inform the community, and individuals have to have the time to say, I don't want any of that, or to say, yes, I want it. And there are a number of stories time does not allow us to follow. But there have now been probably 15 or 20 national multi-center studies that have followed the waiver of consent that have changed our practice. But these are questions. And when we look at ARDS, this can be extended to that for transport of patients across international borders even, and that has occurred. And so this is the envelope we need to push. But that envelope must be pushed with fully knowledgeable individuals like your center, and I applaud you for doing it.
Did you have a question?
Thanks to Dr. Maddox.
You're out of order because we're out of time.
We have a couple more questions from the internet audience. There is a question from Latin America asking about what do you think about the high cost of the device for low and middle income countries, and what about the cost effectiveness and cost benefit of apply this technology in low income settings?
Yeah, that's another brilliant question. I just wanted to thank Dr. Maddox for his questions too. I didn't get a chance to. I think the comment about PE was excellent, as was the hemorrhagic shock. So I just wanted to go back and say that I think the fundamental principles of resuscitation still apply. Rule out obstructive shock, expand intravascular volume, and then maybe later on down the line consider using Ecmo for select indications. Regarding the cost effectiveness in low-income countries, I think that's an important issue, and I think low and middle-income settings are beginning to use Ecmo. Some of my classmates in the course that I attended in Edmonton were actually from Brazil, and they were actually from the pediatrics world. And so I think ECLS is being used in pediatrics in low-income settings. I think the circuits are getting simpler and simpler. And I wonder if we use ECLS judiciously and early, if we can actually prevent certain downstream morbidities like multi-organ failure, shock liver, renal failure, et cetera, that might in the end even make them, if not cost-saving, but at least cost-effective. So I do think that it's worth people in LMICs to be aware of the technology, to explore it, to see how they can disrupt the industry by making the circuit simpler and easier to use, and then bringing them at the right time to prevent long-term and costly complications.
All right, great, thank you. With that, we'll conclude.